Okay, now we are ready to connect to San Donato to know what happened with the sapien valve case in San Donato. That was the second case of the day, but it took a bit longer than anticipated. So we can see all the team. Massimo, please go ahead.
Okay. Can you hear us, Gianfranco?
Sure, we can hear you.
Okay, thank you very much. Just go quickly to show you the case, introduce the case, but first of all I want to introduce the team that was really helpful this morning, this long morning. I have Luca, Selene, I have Viera here, and our special guest, Mansour, working with us. So please, may I have the slides of the case? So he's a 12-year-old male with a double outer right ventricle subaortic VSD pulmonary stenosis that underwent firstly a BT shunt, then a complete repair with a transannular monocasp patch, and then had a normal life. At some point during the follow-up, he started to complain about short of breath, difficulties to cope with his classmate. He was not able to do sport or physical activity. So we restudied him. Actually, we found that there was a significant pulmonary regurgitation with dilated right ventricle with some degree of RVOT obstruction, but the gradient by echo was no more than 15 up to 20 millimeters of mercury. There was also a suspicion, because it was followed up in another center, of a residual VSD, but we didn't find it. The CPET was more or less normal. You see here the MRI with a 3D reconstruction of the CT scan as well. You see a very large outflow tract with normal pulmonary arteries. We did a reconstruction with engineers that show us that actually was dilated the trunk, and it was clear. But what very important information, we found that the proximal part was the best one if you won't go to plus a valve for this child, because the middle part and the distal part had a very important excursion, systodiastolic excursion. So the idea was to implant a valve. We started with a 3D angio just to check the connection between coronaries and the outflow tract. You can see, can you show please the...
Instead of the slide. Remove the slide.
Okay. Okay. So we did this angio. We checked the coronaries. As you can see, both coronaries are rising from the left sinus, and the balloon, completely inflated balloon up to 30 millimeters, is far away from the coronaries. At that point, Mansour arrived. We started to do measurements. So, first angio, please. Okay. Mansour, you want to comment on these angios?
Yeah, so this is a cranial view of the outflow, and you see the junction of this patch and the RVOT. It's a little bit blurred where they actually unite. So if we go to the next, and you see both PAs are fine.
Next.
And significant amount of regurgitation. Again, the boundaries between the muscular or the contracting part of the RV and this patch is blurred, and it's not in one level. So we wanted actually to have a better anatomical delineation of that landing zone. So we did some cranial angulations, and we did some also some RAO, and we'll show it later on. This is again the same balloon that Massimo used for the coronary, and you see complete here. There is actually some dye making it through, so we realize this balloon is a little bit above the landing zone. So if you go to next, please.
Next. Togliamo quell'immagine, per favore.
So this balloon is inside the patch or the
Next.
MPA, anatomical MPA. So we go next to the next balloon occlusion. So this is the balloon on the landing zone or that junction, and you see no waste. But there is complete obliteration of the dye. There is no dye making it through. So Massimo at the time, he says this is 30. We went ahead and measured it, and it was 30. So we scratched our head and we said, shall we do it or not? Because if we stent this lesion with 30, then perhaps he's not going to be at the present suitable for valve. So if I may ask, how many of the audience will go ahead and try to stent this lesion? Just a very crude, estimation. How many of the audience will go ahead and try to stent this lesion?
Can you raise your hand? Who would stent this lesion? So, a few who wouldn't stent.
I would also gently pull and push the balloon to get an estimation if you get any grip at all.
So,
Not only balloon occlusion.
So majority of, lots of people will go ahead and stent with the tug maybe.
Yeah.
So, and that's what Massimo said to me. He said to me, look, I want to be more careful. So he suggested the tug. So can we go to the next, please? And here is the long fluoro recording of the tug. And you see there is no waste whatsoever. If you go to the next, please. I think
Next.
the tug is the next one.
Next.
Yeah, here. Just stay there. Yeah, and you see it jerks a little bit, and Massimo was holding it, and he was jerking it, and he says, Mansour, it's stuck. So I think we can go ahead and stent it. So I said, why we don't go live and ask the people? He says, no, we have no time, we have another case. So we went ahead, and if you want to pick up the story from there.
Okay. So we decided to implant a stent, a Andra XXL 39 millimeters, mounted over a balloon. It was a B balloon, 30 millimeters with 40 length. Next. Okay, next. So we were very happy with the position because we inflate the inner balloon. At that point we decided to go straight forward with the outer balloon. Please, next. Okay, so inflate, Luca. Go. Next. That was what's happened.
So there is a lot of loss of volume. We couldn't get that.
You see, the balloon was just inflated in the proximal part, not in the distal part. We did a couple of adjustments with the syringe because we were thinking about some leak outside. But actually, we realized that the balloon, because of some blood came back, the balloon actually was at least, I don't say broken, but at least fissured.
And it's a mystery. We couldn't identify why did this happen, but we were sure that the balloon didn't have really an integrity anymore because we kept sucking blood. So at this point, we have a partially inflated balloon and an 18 long Mullen sheath there with a lander quest with a defective balloon. So can we ask anybody there, what do we do now? What do you suggest we do?
Are there suggestions, Kevin?
Maybe a 50cc syringe and inject as fast as you can, or connect it up to the pump.
And that's what we did, and unfortunately we didn't record that, but it didn't do anything. The whole thing went with a very high pressure and nothing happened. So any other suggestion? Should we call the surgeon now?
No. Hi, Mansour.
What do we do?
This is Ahmed.
Yeah.
Yeah.
Yes, Ahmed.
I could push the, I would push the balloon stand as supply a little bit distal, and then without preventing the milking back, and then exchange the balloon, and then semi-inflate it, and then come back, and then inflate it at the ROIT. I have encountered such a problem, balloon rupture and incomplete expansion of the stand. I do it, and it worked.
Okay, we try to do this. The problem with this is that because this balloon is now used, so it has a very high profile, so we try to detangle it from the system and pull it through the sheet. It won't pull. It will pull the whole system back. So that was not really very workable solution. But just for the sake of the time, I am going to ask for one last suggestion, and that's what we did. Any other suggestion than what Ahmed suggested?
Just maybe, Kevin here again, maybe just cover the back of the balloon with the sheath and then try and inflate.
No.
Okay, well,
I've never seen such
we
a thing.
realized that...
But maybe
Okay.
you can deflate the inner balloon a little bit and try with a smaller inner balloon to inflate the big balloon. Maybe this would work.
Okay, that was something, just to address Kevin's point, the proximal part of the balloon we think is the intact part, and I think the leak is happening distal. So just for the sake of the time, what we did is something we have faced, and I'm going to move to Massimo, so he will tell you what we decided to do.
So actually it was a Mansour idea to try to pass just parallel into the stent, parallel to the broken balloon. We tried a lot, but finally he succeeded. Please, next, yes, next, 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 next.
He can show the wire.
You see?
We try with coronary wire first, and it will make it through the side stent. So next, please. So this is a parallel pass, and every now and then we wanted to make sure that the stent is not coming down. Next. Now the balloon is partially deflated, so go next, please. This is also a false pass. Next.
Next.
And then Massimo suggested that we use a better wire, a 35 wire, because this catheter will not follow. So next please. So eventually we passed, so these are false passage. Next.
Next.
Next. Next. So this is the time, just go back please.
One back.
Go back. So this is the time we succeeded to put a 4 French catheter parallel to the defective system. And then can you take it over, please?
So we put next. We stabilize all the system for the other groin. Next. And we were able to put an unplugged super stiff 035 guide wire, please. Next. Firstly, we tried to put an unplugged guide wire. That's important. I tried to put a second, no, back a little bit, a second B balloon, 30. The idea was to deflate the first balloon, to pull it back a little bit to advance our balloon. But actually we were stuck into the stent during long time in trying to do this.
That's the reason why Mansour suggests to use a ZMed2 balloon, 30 millimeters diameter. Next. Actually, we succeed. We were able also to put a stiff, a very extra stiff Lunderquist guide wire. Next. We advance step by step the ZMed balloon. Next. 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 Okay. At that point we decided to inflate the balloon. Next. Scratching also the previous balloon. And you see the result.
So how many will stop?
Yes. So, at that point, we were very satisfied.
And this
I
is
don't
30
know you, because the stent in the very good position, stabilized, long time, long procedure. So what you suggested
And this is 30 millimeter.
is a 30 millimeter balloon. Yes. What your suggestion to proceed with the catheterization with the valve, or just to leave the stent there and to put the valve in a second time?
Yeah, first of all, I think you should remove the balloon from there, just to be sure that it is not stuck within the strut of the stents. And then the decision depends upon the amount of contrast, blood gas exam of the patient. If everything is stable and okay, I should go for the valve implant. Also because the satellite is going to break down soon, so we need to have the end of the story.
Please. Next. So we did this consideration with the anesthetist, and we decided to go forward. Next. We decided to implant a 29 millimeter Sapien valve. Free. Next. Next. Okay, next.
Next to the injection after.
Next. Go faster. Okay, faster. Okay, faster. Okay. So we were able to dilate the valve in the right spot. Why we put the valve here and not in the place of the patch, Mansour?
Massimo was pointing all the time to this bulge, and we understood that the lesion, instead of being oval as it is usually, probably has a bulge on one of the patch junction. So we wanted to avoid this as a source for paravalvular leak. So we agreed together that we are going to put the outer skirt is at the second suture, and that will be just at the top of that aneurysm, so we will avoid a paravalvular leak.
Okay.
And
Next. Okay, we did the control angio. Okay. Next.
Yeah, this is good.
There is no paravalvular leak, like you can
This is the
see.
measurement.
We did the measurement. Next, we measured the okay.
Show us.
Just show the measurement of the final diameter here. Okay. Did you record it? It was 30, more or less 30, 29 point something. So I think it was a very good result at the end of the story.
Show the balloon.
Yes.
So we didn't forget, because Massimo says to me, this never happened to me. And I said, it happened to me. So we took the balloon out after we're done, and we wanted to identify what happened to our first
Possiamo
balloon.
mettere l'immagine?
I was the one who was crimping it.
L'immagine.
And I was sure that I was crimping it the right way.
Okay.
So go ahead, please show the picture. So
show
this
the
is
picture.
the defective balloon. And you could see, this, this thing is coming out, and it's a puncture at the tip of it. If you go back, play it, and we think what happened is my eyeglasses is due for change. The lower part is for reading. So I think what happened is when I was loading the stent, and this is the balloon, if you can focus on it, and if you have the mandarin, okay. So the mandarin, there is actually a mandarin wire that is very stiff, and I think I have missed a couple of times putting it on. So I must have punctured this very thin layered, this one. So you see it on the slide. I must have punctured it, this, bib balloon with this mandarin. So I am the one to be blamed, and I'm so grateful that Massimo is such a great operator, and we enjoyed it, and luckily the patient has gone outside of the cath lab with good blood pressure, and everything is very good.
Okay. Thank you very much. So we finished.
We have a comment from the floor. We have a comment from the floor, Evan Zan.
Mansour and Massimo, this is Evan, and first of all, congratulations, because that was incredibly hard to do, and I agree with you. You guys are spectacular operators to be able to get out of such difficult and potentially catastrophic trouble. I would just re-echo what people are tired of hearing me say, but I'm going to say it one more time. What was harder for you guys, putting in the pre-stent or putting in the valve? Mansoor?
Well, as
Mansoor,
it
what
is
was
the
harder?
case, you know that
Yeah.
the stent is always the toughest part.
Thank you. I agree, and we have moved in our institution as well as some of the others around the west coast of the United States to not pre-stenting for the S3 for this exact reason. The pre-stent is really hard to do and fraught with complications, and if you overfill this delivery system by 5 cc's, the outer diameter is 31 millimeters. And if you're confident with your balloon sizing that a 30 millimeter or 31 millimeter stent will stay in place, I will tell you, I believe that the S3 will stay in place, and with the skirt and the longer length, I think that becomes a much simpler procedure. And I just think people should start to give that some thought, again, about doing this without the difficult part, which is the pre-stenting. But congratulations again on a great result.
Okay, thank you very much to everybody. I want to thank all the staff of the Cath Lab because, yes, you need operators, but we need very good staff as we have here. I want to thank all the staff, all our collaborators, all our colleagues, nurses, technicians. Thank you very much. Thank you very much, Mansoor.
Thank you.
Thank you.
Thanks a lot, Massimo. Very well done, and see you soon. So we invite our first speaker of this final session, Kevin Walsh, when to check coronary arteries in an adult with CHD.